This video is all about the pulmonary adjustments to exercise. Hopefully I'll impress upon all of you that the lung in healthy individuals does not limit exercise performance. In fact, the case could be made that the lung is a perfect organ. The topics we'll cover in this lecture include basic anatomy, more importantly how gas exchange occurs, ventilation, that is the gas moving in and out of the lung, diffusion, the movement of gases across the alveolar membrane and into the bloodstream. We'll look at the ventilation to perfusion ratio, that is the amount of gas in the alveolus versus the amount of blood available in the capillaries at the alveolar membrane. We'll look at the mechanics of breathing. We'll look at how ventilation is controlled from a neural and humoral perspective. We'll discuss oxygen transport. We'll also take a look at some special considerations in swimmers. And finally, we'll look at pulmonary diseases, that is chronic obstructive pulmonary disease and asthma. As with most organ systems, we need to understand basic terminology in order to understand how that particular body system works. Pulmonary physiologists are very particular about the terminology, so it's important that you understand all of these terms and how to use them. An uppercase P stands for pressure. An uppercase A stands for alveolar. I want to pause and take a pronunciation break. The words on your screen, alveolar, alveolus, and alveoli, are not pronounced alveolar, alveolus, and alveoli. That's incorrect. The reason why I'm stressing this is because when you're part of an interdisciplinary team, part of healthcare professionals, and you're talking with these healthcare professionals like the MD, I don't want you to sound uneducated. You need to understand this terminology as well as understand the proper pronunciation. Lowercase a stands for arterial. Lowercase v stands for venous. Lowercase v with a line over the top of it stands for mixed venous. Lowercase c stands for capillary. Lowercase c with a line over it stands for mean capillary. I stands for inspired air. E stands for expired air. B stands for barometric. We can combine these letters to make various acronyms in pulmonary physiology. For example, PO2 stands for the pressure of oxygen. P lowercase aO2 stands for the arterial pressure of oxygen. PCO2 is the pressure of carbon dioxide. P uppercase aCO2 stands for alveolar carbon dioxide pressure. PB stands for barometric pressure. Can you think of any other combinations? F stands for fraction or percent. For example, F uppercase aO2 stands for the percent of oxygen in the alveolus. F uppercase eO2 stands for the fraction of expired oxygen. V stands for volume. For example, VT stands for tidal volume. You'll also see it written as TV. VA is alveolar volume. VD stands for dead space volume. VS stands for stroke volume. VL stands for lung volume. V with a dot over it stands for a volume per unit of time. For example, we've seen V.O2. That's the volume of oxygen consumed on a liters per minute basis. As a side note, you can express fractions as, in this example, liters dot minute -1 superscript. And that just stands for 1 over the denominator. You'll often see this in the scientific literature, but they're interchangeable. Uppercase C can stand for concentration or content. Q is another way of saying volume. We've seen this before with the cardiovascular system when we talked about cardiac output. If I put a dot over that Q, that of course stands for a volume per unit of time. The last three acronyms on this page represent how gas exists in different environments. The first of which, BTPS, stands for body temperature, pressure, saturated. That's how a gas exists in the lung. ATPS, ambient temperature, pressure, saturated. That's how gas exists in the atmosphere. STPD, standard temperature, pressure, dry. This is how we standardize gases to a particular temperature, pressure, and humidity level, so that we can have an apples to apples comparison when we're looking at volumes of gas, as in VO2. This slide shows you the basic anatomy of the lung. The lungs consist of the conducting airways, the mouth, the nose, the trachea, and the bronchi. As the bronchi branch into many bronchioles, we have the terminal bronchiole as well as the respiratory bronchiole, followed by the alveolar duct and the alveolus. The functional unit of the lung where gas exchange takes place is known as the alveolus. There is, however, just a little bit of gas exchange that goes on at the alveolar duct as well as the respiratory bronchiole, but not much. It's really the alveolus where we're having the exchange of oxygen and carbon dioxide. Air that moves through the airways does not give up any of its oxygen nor receive carbon dioxide from the blood. They simply conduct the air to the alveoli. For this reason, the airways comprise what we call dead space, or uppercase V, lowercase d, VD for short. The only place where gas is exchanged is in the alveoli. If we were to spread the lung out flat, the alveoli would cover an area of about 70 square meters. That's the size of a tennis court. This is the surface area an adult has available for the exchange of gas from the lung to the blood for oxygen and the blood to the lung for carbon dioxide. Even at maximum exercise, we only use about 80% of the available alveoli for gas exchange. That means we have about a 20% reserve left in the lung. And remember, this is maximal exercise we're talking about here. That is absolutely phenomenal. To have an organ that has that much reserve built into it is incredible. I can't think of any other organ with that kind of capacity. We're talking about 300 million alveoli and 280 billion capillaries to make gas exchange happen. To give you an idea, at rest, about 250 milliliters of oxygen are entering the bloodstream, and then about 200 milliliters of carbon dioxide are actually leaving the blood. During inspiration, the diaphragm muscle is going to contract and move in the inferior direction. In other words, it's going to move downward if we're in an upright position. This movement causes a negative pressure to form in the lungs, and air rushes in from the atmosphere. During exhalation at rest, the diaphragm is going to relax to return to its resting position, and air is forced out of the lungs. At rest, exhalation is passive. The primary muscle of inspiration is the diaphragm. At times, accessory muscles between the rib cage, called the external intercostals, also contract to help inspiration. The primary muscles of exhalation are the abdominal muscles. When exhalation is forced, as during exercise, the internal intercostals between the ribs contract to assist in this exhalation. So what is the function or job of the lung? It's designed to maintain adequate oxygen and to expel carbon dioxide. In this table, we're going to be looking at the pressure of venous oxygen. We'll look at the pressure of arterial oxygen, as well as the pressure of arterial carbon dioxide. At rest, the pressure of venous oxygen sits at about 40 millimeters of mercury. The pressure of arterial oxygen sits at about 92 millimeters of mercury, or if you want to remember an easier number, 90 millimeters of mercury will be just fine. The pressure of arterial carbon dioxide sits at about 38 millimeters of mercury. During moderate exercise, the venous pressure of oxygen drops to 30 millimeters of mercury. That should make sense because muscles are extracting more oxygen. Remember that AVO2 difference. The arterial level of oxygen sits at about 90 millimeters of mercury, so there's not much of a change there from rest to moderate exercise. The carbon dioxide level still sits at about 38 millimeters of mercury. During heavy exercise, the arterial venous pressure of oxygen drops to less than 20, so we've really extracted a lot of oxygen from the arterial system. So we've really unloaded a lot of oxygen to the working muscle. Now look at this. The arterial pressure of oxygen actually increases to about 95 millimeters of mercury. So we get even better oxygen pressure with heavy exercise. We'll look at the specific mechanisms that make this happen a little bit later on. The carbon dioxide level will drop down to about 32 millimeters of mercury. The entire respiratory system is designed to deliver the appropriate amount of oxygen and get rid of the carbon dioxide level during exercise. It really is a remarkable system. Atmospheric gas is going to contain these primary elements: oxygen, carbon dioxide, and nitrogen. There are other atmospheric gases that exist, the inert gases that have no bearing on gas exchange, so we're just going to ignore them. FiO2, or the percent of oxygen inspired, is always going to be 20.9%. That number does not change. FiCO2 stands for the percent of inspired carbon dioxide. That sits at 0.04%. And that too will never change. FiN2 stands for the percent of nitrogen inspired. That will always be 79%. So these are standardized percents of gases in the atmosphere. Now what does change is the barometric pressure. At sea level, the barometric pressure is about 760 millimeters of mercury. So the pressure of inspired oxygen at sea level, or 760 millimeters of mercury, will be about 159 millimeters of mercury. How did I get that? I took the FiO2 of 0.21 and I multiplied that by 760. If I do the same thing for nitrogen, I get 600 millimeters of mercury. So 0.79 times 760. Please take a moment and figure out what the FiCO2 would be at 760 millimeters of mercury. Or better yet, look up the barometric pressure in your neighborhood and figure out what these pressures are in millimeters of mercury. This figure shows the change in partial pressure of oxygen as it is inspired from the ambient air into the alveolus, then transferred into the capillary, and collected into the arterial blood to the body tissues. Please note that the oxygen venous pressure is also shown here for reference. On the y-axis, we have the pressure of oxygen. On the x-axis, we have oxygen at the level of the lung, as well as systemic and venous circulation. At sea level, or a barometric pressure of 760 millimeters of mercury, we said that the oxygen pressure is about 159 millimeters of mercury. As we breathe in air and it passes through the nose and the mouth and the trachea and the bronchi, we lose some oxygen pressure due to the fact that there is no gas exchange occurring in those areas. We call that dead space. So our oxygen pressure now might be at a level of 155 millimeters of mercury. The drop in the pressure of oxygen from inspired air to alveolar air is going to be what we call ventilation dependent. That is, how and how much we breathe is going to be responsible for the pressure differences that we see in oxygen. The drop in oxygen pressure from alveolar air to capillary blood is going to be what we call diffusion dependent. This will be reflected in the surface area available for gas exchange. That's going to be dependent upon the pressure gradient as well as the amount of capillaries that are perfused with blood. As we move that gas from capillary blood to arterial blood, we're going to see another drop. We say that that is VAQC dependent. That is, how well matched are the alveoli to the capillaries. The drop from arterial blood to the venous system makes sense because we are extracting oxygen from the blood, therefore that pressure is going to drop. So let's take a look at each of these three areas in greater detail in terms of how they affect pulmonary gas exchange. That is, we're going to look at ventilation, diffusion, and the VAQ matching and how that affects gas exchange in the lung. The first thing that we need to understand is that as air enters the lung, oxygen is going to be diluted with water vapor. The lung is a very moist environment and the vapor pressure is about 47 millimeters of mercury. What we don't want to forget about here is that as gas enters the lung, carbon dioxide is already present, exerting a certain amount of pressure. Remember that alveolar pressure is about 45 millimeters of mercury. So only so much gas can come into the lung because CO2 will displace some of that gas out and therefore some of that oxygen out, thereby lowering some of the pressure. So we lose some oxygen pressure simply by the fact that there's water vapor as well as carbon dioxide present at the level of the alveolus when we're inhaling. So what would happen with a breath hold? In other words, if I plug my nose and hold my breath. So I'm going to do this. What's going on with the alveolar oxygen level as well as the alveolar carbon dioxide levels? Oxygen levels should be dropping because I'm utilizing that oxygen, and carbon dioxide levels should be increasing because I'm producing carbon dioxide as a waste gas. So in a breath hold, we are underventilating the lung. That is, we're decreasing alveolar oxygen pressure and increasing alveolar carbon dioxide pressure. Conversely, if I overventilate the lung, then I'm increasing ventilation without an increase in oxygen consumption. This is therefore going to increase alveolar pressure of oxygen and decrease the alveolar pressure of CO2. A good example of overventilation is that of hyperventilation. Let me demonstrate. In this example, my pressure of alveolar oxygen is increasing and the level of carbon dioxide pressure is decreasing. In pulmonary physiology, the very definition of hyperventilation is that I have a decrease in the amount of pressure of carbon dioxide in the venous system. So it's not how a person looks, it's not how a person sounds, it's not how hard someone's breathing, it's all about what's going on in the venous system in terms of carbon dioxide pressure. Now, if somebody is experiencing some decreases in carbon dioxide level and they're starting to get dizzy, that's where a paper bag really comes in handy. When I breathe into that paper bag, the level of carbon dioxide pressure will increase because I'm exhaling some carbon dioxide and then breathing that gas back in. So that rectifies the situation and brings the oxygen and carbon dioxide levels back to normal levels. So it's important to note that hypo or hyperventilation is defined only by the change in arterial carbon dioxide. An increase in ventilation with no change in arterial pressure of carbon dioxide, as during moderate exercise, is defined simply as hyperpnea. Continuing on with the ventilation drops from inspired to alveolar air as far as oxygen pressure is concerned, is that of understanding how and how much we breathe. Minute ventilation, or V.E, is equal to Vt times Fb. That is, tidal volume times the frequency of breathing. How much we breathe is what we refer to as minute ventilation. That's the overall volume of gas moving in and out of the lung. Tidal volume and frequency of breathing describes the pattern of breathing. That's what I'm referring to as how we breathe. We have two options when it comes to changing how much we breathe. That is the overall volume, or V.E. We can change how deep we breathe, so the tidal volume, and we can also change the frequency of breathing, so how often we breathe. Let's put some numbers to how and how much we breathe. At rest, our tidal volume is about 500 milliliters, or a half a liter. During exercise, tidal volume can reach 3 liters. At rest, the frequency of breathing is about 15 per minute. During exercise, that can increase to about 50 per minute. If we multiply these variables together, that is tidal volume times the frequency of breathing, we come up with minute ventilation. At rest, that's about 7.5 liters per minute. During exercise, that's about 150 liters per minute. The amount of dead space volume contributing to each breath is about 150 milliliters, or 0.15 liters. We can determine the dead space volume by mathematically rearranging these formulas so that we come up with the VD to VT ratio. What I'd like you to do is to calculate the VD to VT ratio for both rest and exercise and see what the dead space contribution is going to be for both of these conditions. If you've done your calculations correctly, at rest, the contribution of dead space to each breath is about 30%, whereas during exercise, that gets reduced to only 5%. So how we breathe during exercise makes a big difference in determining the dead space contribution to each breath. That's going to affect the pressure of oxygen available for gas exchange. So during exercise, I get more efficient in that I reduce the dead space contribution to each breath. So when we exercise, we increase our total ventilation by increasing the tidal volume and breathing frequency. So how much and how we breathe in response to exercise is critical in determining the levels of oxygen and carbon dioxide in the lungs and ultimately how much oxygen gets into the blood. The air has a mass that creates air pressure. Think about the pressure of air in your tires. The pressure of a gas in the lungs determines to a great extent how that gas will be transferred across the lung membrane into the blood flowing past the membrane. In the next section, we're going to talk about the pressure drop from alveolar oxygen to capillary oxygen pressure. This is where we'll discuss all the diffusion properties that affect the drop in this oxygen pressure that we see. What we're really talking about here is the surface area available for gas exchange, or the area of interface between the air and the blood. So that's where the air, this gas, is meeting the blood. Both of these factors, the driving pressure and the surface area, determine how much a gas will diffuse from the lung into the blood. It's important to note that the alveolar membrane does not provide a significant barrier to gas exchange. It's more dependent upon how well perfused, that is, how much blood is in the capillaries, and the pressure gradient, which is, of course, as we just talked about, dependent upon ventilation, how and how much we breathe. So in this diagram, we've got two areas that we're looking at. We're looking at the gas that's in the level of the alveolus and the blood in the capillaries. The alveolar membrane is represented by the arch in blue, and the red circles are the capillaries. The driving pressure is represented by the downward arrows. The ability to diffuse oxygen from the lungs into the blood is dependent on the pressure gradient driving the oxygen across the lung membrane and how much lung and blood interface or surface area is available. At rest, the driving pressure is small and the surface area between the blood and gas is small. During exercise, both the driving pressure and the surface area increase, thereby increasing the movement of oxygen from the lungs into the blood. So let's summarize everything we've talked about up until this point. The lungs are going to optimize the potential for gas exchange by increasing minute ventilation or how much we breathe. The lungs will also increase alveolar ventilation by manipulating how we breathe, that is, manipulating tidal volume and the frequency of breathing. This actually will help decrease the VD to VT ratio, that is, we have less contribution of dead space to each breath. We also increase the lung diffusion of gases by increasing the surface area for gas exchange and capillary volume and pressure gradient. Regardless of how much oxygen is in the lungs or how much surface area is available for diffusion, if the gas in the lung isn't matched with the blood flowing through the lung, the arterial pressure may not be optimized. This is what we call the VAQ matching. That is the alveolar ventilation versus the amount of perfusion in the capillaries at the level of the lung. This contributes to the pressure drop of oxygen pressure in the capillaries to the arterial system. So let's put some numbers to understand this concept a little bit better. At the top of the lung, we have alveolar ventilation at 0.24. We have perfusion, or Q, at 0.07. When we do the math, we have a VAQ matching of 3.3. At the bottom of the lung, alveolar ventilation is 0.82, perfusion is 1.29, for a VAQ matching of 0.63. On average, this gives us an alveolar ventilation of 5.1, perfusion of 6, for an average of 0.84 for the VAQ matching. So what do all these numbers mean? What am I looking at here? Basically, the closer we are to a ratio of 1.0, the more perfect the matching would be. So in other words, at a ratio of 1.0, I would have an equal amount of gas matched with an equal amount of blood, so that there's good gas exchange occurring. A ratio of 3.3 tells us that we have a large area of the lung that has a lot of gas present, good ventilation. A ratio of 0.63 indicates that there are more capillaries that are perfused with blood and fewer areas that have gas available. In reality, what happens is that we have an average of all these areas so that we come up with a general ventilation to perfusion ratio. So a ratio of 0.84 would just indicate that we are favoring the side of blood perfusing capillaries versus gas available in the alveoli. It's important to note that the lung does have gradients between the amount of gas that's available as well as the amount of capillaries that are perfused with blood. In this slide, we're using the Slinky model of the lung to help explain the uneven distribution of air breathed into the lung. The relatively unstretched bottom part of the lung at the end of a normal expiration can expand more during inspiration so that more air goes to the bottom than to the top of the lung. As air is inhaled, and in this case the spring is pulled from the bottom, the space between rings increases more at the bottom than at the top. Part of the reason is that the rings at the top are already stretched and are therefore more difficult to stretch than the ones at the bottom. At rest, the lung is similarly stretched. At the end of a normal expiration, there is more air in the top, but when air is inspired, more of that air goes to the base of the lung. This uneven distribution of air in the lung is due to the effect of gravity and happens in all body positions. To illustrate this point, let's use this figure. On the y-axis, we have alveolar ventilation per minute, and on the x-axis, we have the anatomical distribution of the lung. So the bottom of the lung is on the left, the top of the lung is on the right. The solid white line represents the upright position. The dashed white line represents the supine position, or laying on your back. The red line represents exercise. So what does this graph tell us? In the upright position, what we see is that alveolar ventilation is higher at the bottom of the lung versus the top of the lung. In a supine position, that alveolar distribution is more even, so now there's more equal distribution of gas across the lung. During exercise, alveolar ventilation does increase, but look at the distribution. It is very similar to the supine position. So the effect of gravity during exercise is diminished in terms of alveolar ventilation, and there are mechanisms in place that ensure that we have a better distribution of gas throughout the lung. The increased top to bottom expansion of the lung during exercise results in a more even distribution of the ventilation. The exercise-induced improvement in alveolar ventilation distribution, along with the previously discussed overall increase in alveolar ventilation, ensures that virtually all alveoli receive an exchange of air with each breath. In addition, the better distribution of alveolar ventilation and increase in alveolar ventilation ensure that blood perfusing the lungs will be exposed to the lung oxygen. This slide also shows that the distribution of blood perfusing the lung is also gravity dependent. Because of the effect of gravity in an upright position, the blood that's being pumped out of that right ventricle and distributed to all the capillaries surrounding the alveoli gets pushed more so to the bottom of the lung versus the top of the lung. To illustrate this concept, let's look at this diagram. On the y-axis we have cardiac output, and on the x-axis we have the anatomical location of the lung. The bottom's on the left, the top's on the right. The upright position is represented by the solid white line, the supine position is represented by the dashed line, and exercise is in red. What we see are similar effects of gravity on blood distribution in the lung going from an upright to a supine position to exercise in the upright position. We get better distribution of blood in the supine position as well as during exercise. So let's look at the VAQ matching under different conditions. So at rest, the VAQ is about 1. Meaning that alveolar ventilation is well matched with perfusion. During moderate exercise, the VAQ will go up to 1.5, so there's more ventilation than perfusion. During heavy exercise, that ratio can approximate 2.5, again meaning that there is more ventilation than perfusion. While a VAQ ratio of more than 1 would show poor matching, that is, a greater amount of ventilation compared with the available perfusion, this generally results in good gas exchange because the blood that is perfusing the lung has a much higher probability of interfacing with well-ventilated alveoli. So during upright exercise, the increased cardiac output and outflow pressures result in a more even distribution of blood flow in the lung, ensuring that blood flowing through the capillaries surrounding the alveoli is more evenly distributed than at rest. The more even distribution of cardiac output during exercise ensures good matching with the alveolar ventilation, which also is more evenly distributed. The VAQ ratio reflecting the matching of lung air and blood is dramatically improved during exercise. An improved VAQ is a direct result of the exercise-related distribution of both alveolar ventilation and cardiac output in such a way that a close interface between the two is maintained or increased. The significantly increased alveolar ventilation ensures that virtually all of the blood entering the alveoli will be exposed to fresh, oxygen-rich alveolar gas. So let's summarize everything that we've talked about thus far with gas exchange. How much we breathe is going to determine alveolar oxygen. That is, the overall amount of minute ventilation. How we breathe determines the relative contribution of dead space to alveolar ventilation. That is the manipulation of the frequency of breathing as well as tidal volume. The diffusion of gas from the lung to the blood is dependent upon two things, the driving pressure as well as the interface between the capillaries and the alveoli. So how much surface area is available for gas exchange? The matching of alveolar ventilation and cardiac output through capillaries becomes much better. Both of these become more evenly distributed during exercise. So here's a question for you to think about. Given what you know about the cardiovascular and the pulmonary systems, why are children better able to compete with adults in swimming, but not other athletic events such as track and field? The answer to this question lies in the optimization of stroke volume, alveolar ventilation, cardiac output through the capillaries, and the VAQ ratio in the supine position. Young swimmers are better able to compete with adults because of the supine position and the effects that gravity have on these variables. The relatively small heart volume and therefore stroke volume and smaller lung surface area in children as compared with adults are less of a limiting factor during exercise in the supine position than in the upright position. So the arterial pressure of oxygen is going to be maintained or actually increased during exercise by increasing minute ventilation with increases in tidal volume such that there is less wasted ventilation in dead space. So the dead space contribution to each breath is reduced. There's an improvement in the pressure gradient and area available for diffusion. And there's also an overall improvement in the VAQ matching. Let's move on to the mechanics of breathing and discuss lung volumes. In this graph, I'm breathing in and out, and then I take a deep breath in and then a deep breath out. The amount of air that we move in and out of the lung at rest is what we call tidal volume. The average adult has a tidal volume of about 500 milliliters. That is, they breathe in and out 500 milliliters with each breath. This line represents the end expiratory lung volume. That is, once expiration is complete, this is the volume of air that's left in the lung. When we relax at end exhalation, or the EELV, the pulmonary system is in balance. That is, the tendency of the chest wall to want to flare out is balanced by the tendency of the lungs to want to collapse. The chest wall is actually holding the lungs open, and the lungs are pulling the chest wall in. At this balance point, we don't expend any energy to breathe. To inspire or exhale away from EELV requires muscular activation and therefore energy consumption. Just as a fun fact, if you've ever watched the 1989 movie National Lampoon's Christmas Vacation starring Chevy Chase, you will actually see the tendency of the chest wall wanting to expand out and the lungs wanting to collapse. There's a scene where Clark is carving into the turkey, and if you look close enough, you'll actually see a little set of lungs collapsing and, of course, the rib cage flaring out. So if you got some spare time and you want to see that effect, go ahead and check that flick out. This top line represents the inspiratory capacity, also known as the IC. So this is the maximum amount of air that we can inspire in a breath. In the average adult, that's about 3 liters or 3,000 milliliters. This bottom line represents the expiratory reserve volume. This is the amount of gas that we can forcibly exhale from the lung. The average adult has an ERV of about 1,200 milliliters. When we combine the ERV with the inspiratory capacity, we get the VC or vital capacity. The average adult has a VC of about 3,500 milliliters. Beyond the ERV, we have the RV or the residual volume. The average adult has about 1,200 milliliters. This is the amount of air that's left in the lung even after maximal forced exhalation. This air we cannot get out of the lung, and it's due to that balance between the lungs wanting to collapse and the rib cage wanting to expand. When we combine the RV with the ERV, we get the FRC. This is the functional residual capacity. The FRC represents the volume of air left in the lungs at the end of a normal relaxed exhalation. It's important to remember that the FRC represents the point at which the pulmonary system is not going to expend any energy to maintain that volume, and that any movement away from that point is going to be accomplished only with the expenditure of energy. To conserve energy, the respiratory system tends to remain as close as possible to the FRC. I wanted to take a moment to stress that the rib cage wants to naturally flare outwards, whereas the lungs want to collapse. That balance between those two is what we call the FRC. This is where no energy is expended. So if we want to flare the rib cage out, we want to breathe in deeply, that's going to increase energy expenditure. If we want to exhale forcibly and let those lungs collapse, that's going to increase energy expenditure. These concepts are going to be really important when we talk about lung disease. All of these lung volumes are what we refer to the total lung capacity, or TLC. The average adult has about a 6-liter TLC. So let's summarize all the concepts that we've learned up until this point. We've talked about gas exchange. How much we breathe is going to determine alveolar ventilation of O2. How we breathe determines the relative contribution of dead space to alveolar ventilation. So what's the contribution of dead space to each breath? The diffusion of gas from the lung to the blood is going to be dependent upon the driving pressure of that oxygen, as well as the interface between the capillaries and the alveoli, or the total surface area available for gas exchange. The matching of VAQ and QC becomes better with exercise. Both become more evenly distributed. In terms of the mechanics of breathing, we talked about the FRC, or the functional residual capacity, being the balance of the chest wall and the lung forces. We increase tidal volume to stay as close as possible to the FRC while minimizing the contribution of dead space to each breath. The work of breathing is a powerful influence over how and how much we breathe. We breathe in a way to minimize the work of breathing. The work that the respiratory muscles have to accomplish in order to overcome any changes away from FRC are due to the elastic forces in the lung. And we can feel these elastic forces by doing some simple activities. So first, what I'm going to do is I'm going to inhale very deeply and then cover my mouth and nose with my hand to experience that pressure change. Here we go. In this situation, I could feel the positive pressure that is being generated from the air exhaling to bring my lung back down to FRC. That's the elastic nature of the lung wanting to collapse that I'm feeling. Now let's do the opposite situation. So I'm going to exhale forcefully, and then cover my mouth and nose again. Now I can feel negative pressure for the rib cage, or the elastic nature of the rib cage wanting to expand back out to bring my lung volume back to FRC. The generation of inspiratory and expiratory forces represents work done by the respiratory muscles against the elastic structures of the respiratory system and represent the elastic work done by the system. During quiet breathing, exhalation is a very passive process in which the elastic structures recoil back to the FRC after being stretched during inspiration. During exercise, the elastic work of each inspiration and exhalation is minimized by breathing as close to the FRC as possible. Energy expenditure to move the elastic structures of the lung is going to be minimized when we avoid breathing at very high or very low lung volumes. In order to move air in and out of the lung, the respiratory muscles not only have to overcome the elastic forces, but they also have to overcome what we call the flow resistive forces. That is the movement of air in and out the conducting pathways. To illustrate this point, I have a straw here, and I would recommend that you try this at home as well. This is a really great way to illustrate this point. I'm going to plug my nose and then breathe in and out of the straw. That's a great way to feel the flow resistive work. When you increase the frequency of breathing through the straw, you really can feel the flow resistive work that the respiratory muscles have to overcome in order to accomplish breathing properly. So the energy expenditure required by the respiratory muscles is to overcome the elastic forces of the lung and chest wall, as well as the resistive forces related to the air movement in the airways. Let's look at the energy cost of respiratory muscles related to the work that has to be overcome with the flow resistive forces as well as the elastic forces. In this diagram on the y-axis, we have the energy cost to attain a given level of ventilation. On the upper x-axis, we have the breathing frequency. As we go from left to right, we increase the breathing frequency. On the bottom x-axis, we have tidal volume. As we go from right to left, we increase the tidal volume. The elastic work is represented by the white dash line. The flow resistive work is represented by the blue line. The total work performed by the respiratory muscles in order to overcome the flow resistive and elastic work is represented by the green line. If we increase the breathing frequency, the flow resistive work increases, as you see by the blue line. With an increase in breathing frequency, the amount of elastic work actually decreases. Conversely, if I increase the tidal volume, that's going to increase the amount of elastic work that I have to accomplish, but decreases the amount of flow resistive work that I have to do. As a point of clarification, if I breathe deeply, so if I do something like this, that's going to increase the amount of elastic work that I have to accomplish with each breath. So therefore, that's going to increase my energy expenditure. Conversely, if I take shallow breaths, so something like this, like panting, that's going to increase the flow resistive work that I have to accomplish. So either one of those scenarios is going to increase my energy expenditure. So I need to find a combination of both the depth of breathing as well as the frequency of breathing that minimizes the energy cost to breathing. If we combine the flow resistive and elastic work, we can get the total work. As you can see, there's a trough in the middle of this diagram. This trough represents the point at which the energy cost for breathing is minimized. So the lung finds the best combination of breathing frequency and tidal volume where the energy cost is going to be at their lowest. So the human body tries to find the most energy efficient way to breathe. The energy required by respiratory muscles is less than 5% of the total oxygen consumption. So you can see that the lung is very efficient at moving air in and out of the lung. At rest, ventilation is about 0.5 to 1 milliliter of oxygen per liter of ventilation at rest. During exercise, this increases only to 2 to 3 milliliters of oxygen per liter of ventilation. That's pretty impressive. So here are the concepts thus far that you should have a good understanding of. We've talked about the oxygen cascade, how oxygen transport is dependent upon how and how much you breathe. We talked about the diffusion contribution to that, as well as the VAQ matching. We've also talked about the mechanics of breathing, how the elastic and flow resistive forces contribute to the work of breathing. What are the mechanisms responsible that mitigate these forces that we have to contend with? On each of these y-axes, we have the frequency of breathing, tidal volume, and minute ventilation. In all of these figures on the x-axis, we have oxygen consumption in liters per minute. This represents the exercise intensity. So as we move from left to right, the exercise intensity is increasing. Please recall that minute ventilation is simply the frequency of breathing multiplied by the tidal volume. During low to moderate exercise, tidal volume is going to increase in order to mitigate the contribution of dead space volume to each breath. This ensures that we waste less gas in those conducting pathways that do not have any gas exchange occurring in them. If you recall, by increasing tidal volume, we can actually reduce the dead space contribution to each breath from something like 30% at rest to less than 10% during heavy exercise. In addition to increasing tidal volume, we do increase the frequency of breathing. However, it remains fairly linear until exercise intensity gets really high. At that point, then we have a significant increase in the frequency of breathing. Remember that increasing the frequency of breathing is going to increase the flow resistive work that we have to accomplish, whereas increasing tidal volume increases the elastic force that we have to overcome in order to accomplish breathing. When we combine these two to make minute ventilation, we might get something that looks like this. So minute ventilation increases with exercise intensity fairly linearly. However, at some point, we have an exponential rise in minute ventilation. The point at which VE increases at a proportion to the increase in VO2 is what we call the ventilatory threshold. Healthy sedentary people will reach this point at about 60% of VO2 max, whereas athletes may not reach this point until 80 or 90% of VO2 max. Essentially what's happening at the ventilatory threshold is that we have an increase in the production of lactate from muscle that's being dumped out into the bloodstream. So to accommodate this increase in acid, we have to increase minute ventilation. As these graphs indicate, we tend to increase the frequency of breathing at the higher intensities past this ventilatory threshold more so than the tidal volume. The increase in minute ventilation that is fairly linear is what we call the slow component, that's represented by the letter A here, whereas the fast component, represented by B, is where we have an increase in the amount of minute ventilation occurring past that ventilatory threshold. The control of exercise ventilation is accomplished by the nervous system as well as factors in the blood. In this diagram, we have on the y-axis minute ventilation, and on the x-axis is time of exercise. The increase in minute ventilation that we see initially is going to be due to the nervous system. So that's a neural component. That's what we call the gross on-off switch. So all of the proprioceptors located in joints and at the lung sense that movement is occurring. This increases ventilation. As exercise continues, the humoral factors, or that is the components in blood, things like CO2, are increasing, which then contribute to the increases in ventilation. This is what we call the fine-tuning of the system. This leads to better matching of the increase in minute ventilation with energy expenditure. In other words, what we're trying to do is we're trying to minimize the energy cost of breathing while still providing sufficient ventilation to perform the given level of exercise that we want to accomplish. So as we've talked about in the past, the nervous system has proprioceptors located in muscles and joints that are all movement stimulated. The more stretch that's being placed on these proprioceptors, the more that you're going to get an increase in ventilation. Same thing with mechanoreceptors located in the lung. These are sensors that are receptive to the stretch of the lung. Again, this is the gross on-off switch. So as we begin the exercise, we're moving, we're stretching these receptors, and that's causing a direct increase in ventilation. To more finely tune the system and adjust ventilation accordingly, we rely on humoral factors. There are central receptors located in a variety of locations like the carotid arteries that sense oxygen, as well as in the medullary cardiovascular center that are going to sense the amount of carbon dioxide level. These will help fine-tune the ventilatory responses. When it comes to increasing ventilation, which one takes precedence, the oxygen or the carbon dioxide? Let's take a look at these two graphs at the bottom of the screen here to figure this out. In this first diagram, on the y-axis we have minute ventilation, and on the x-axis we have the percent of inspired oxygen. It's important to note that inspired oxygen as a percent doesn't change, but in this particular study, that percentage of oxygen was exogenously manipulated. In other words, they placed the subjects in a chamber and then manipulated the percent of oxygen available to breathe. So what does this graph tell us? As we go from 21% oxygen, we see that we can reduce that percent of oxygen all the way down to about 12% before we get an increase in minute ventilation. If oxygen pressure is reduced to less than 12%, then you see minute ventilation increase significantly. The panel on the right-hand side of the screen also has minute ventilation on the y-axis, but on the x-axis we have the percent of carbon dioxide that's inspired. This is again exogenously manipulated. That is, we've put somebody into a chamber and we've manipulated the amount of carbon dioxide available to breathe in that chamber. What do we see here? There is a very linear response. So as we increase the amount of carbon dioxide percent from 0 to 5%, there's a one-to-one relationship. Minute ventilation increases with each percent increase in carbon dioxide. So the answer to the question of why do we breathe really comes down to the level of carbon dioxide in the blood. If carbon dioxide increases, we're going to increase ventilation. So we're not really breathing because of oxygen, we're breathing because of CO2 to get rid of that CO2 from the blood. The medullary center is very sensitive to carbon dioxide. That's the stimulus for us to breathe. And again, we're sensing this in peripheral receptors as well as central receptors. Basically, what we're sensing is the change in pH. So if we decrease pH, that means that we're increasing the concentration of hydrogen ions. So the blood is more acidic. If you recall, the pH of blood is about 7.4. So during exercise, we have to mitigate the changes in pH. The following equation is what we call the Henderson-Hasselbalch equation. This is how we buffer any changes to pH in the blood. If we start on the right-hand side of the equation where we have the production of hydrogen ions, that combines with bicarbonate, HCO3. Bicarbonate's produced by the kidneys. The more bicarbonate we have, the higher the ability to buffer any acid that's introduced into the blood. Where's the acid coming from? Don't forget about metabolism, the production of lactate. The combination of hydrogen ions with bicarbonate then produces H2CO3, which is carbonic acid. Carbonic acid then, once that reaches the level of the lung, dissociates very quickly into carbon dioxide and water. Remember, at the lung, there's water vapor pressure. That's where that water is coming from. Of course, CO2 is left there, and that's released or expelled out into room air. So by breathing more, increasing ventilation that is, we have a buffering effect on the blood. The increase in hydrogen ions decreases pH, which then causes an increase in minute ventilation to expel that carbon dioxide. If the lung is damaged or limited in expelling carbon dioxide, what would happen is we would have a condition known as respiratory acidosis. In this diagram, on the y-axis, we have minute ventilation, and on the x-axis, we have intensity of exercise. What we see is the contribution of several components to increases in minute ventilation. So our muscle afferents are going to increase ventilation because of all of that proprioceptive input, so this is the neural component. We know that an increase in pH is also going to increase minute ventilation, simply to get rid of that carbon dioxide. But we also know that an increase in temperature is going to increase minute ventilation. The increase in body temperature seen with exercise, especially at higher intensities, seems to stimulate directly the medullary control center. There also appear to be other factors that we're just not aware of that also contribute to an increase in minute ventilation. It's important to remember that ventilation is going to be higher at the same given level of VO2 during arm work compared with leg work. Let's not forget what we've learned in previous lectures. So what are the points that we've discussed thus far? We've talked about gas exchange and how that is ventilation, diffusion, and VAQ matching dependent. We've talked about the mechanics or the work of breathing, how we have to overcome the elastic forces as well as the flow resistive forces. We've just talked about the control of breathing, all the neural input that we have from proprioceptors and mechanoreceptors, as well as the humoral components and how they're used to fine-tune the acid-base balance of the blood using things like carbon dioxide, hydrogen ions, and to some extent oxygen. Let's talk about oxygen and carbon dioxide transport in the blood. Oxygen is transported in the blood both on hemoglobin as well as dissolved directly in the blood. The hemoglobin molecule consists of a central protein called the globin, which is surrounded by 4 iron-associated hemes. Each of these hemes can carry 1 oxygen molecule, so 1 hemoglobin can carry 4 oxygen molecules. 1 gram of hemoglobin can carry 1.3 milliliters of oxygen if it's fully saturated. Assuming a normal blood hemoglobin level of 15 grams of hemoglobin per 100 milliliters of blood, and that each hemoglobin is fully saturated, we could carry 20.1 milliliters of oxygen per 100 milliliters of blood attached to the hemoglobin. If we also factor in the amount of oxygen that's directly dissolved in blood, the total concentration of oxygen then would be 20.4 milliliters of oxygen per 100 milliliters of blood. The binding of oxygen to hemoglobin allows the transport of a very large amount of oxygen with a very small cardiac output. To transport that same exact amount of oxygen without hemoglobin would necessitate a cardiac output of over 80 liters per minute. During exercise, that figure jumps up to 1,500 liters per minute. So the take-home message here is that hemoglobin really allows us to transport a large amount of oxygen with very little cardiac output. The amount of oxygen that's carried on the hemoglobin molecule is really dependent upon the pressure of oxygen. This is a classic diagram that shows the relationship between arterial saturation of oxygen on hemoglobin versus the pressure of oxygen in blood. On the y-axis we have the percent arterial saturation of oxygen on hemoglobin, and on the x-axis we have the pressure of oxygen in millimeters of mercury. The dashed line represents 100% saturation of hemoglobin with oxygen. The white S-curve represents normal pH levels, so normal carbon dioxide levels. The blue curve represents a high blood pH or the low pressure of carbon dioxide. The red line represents low blood pH or a high pressure of carbon dioxide. At a normal arterial pressure of oxygen of 90 millimeters of mercury, the hemoglobin is about 96% saturated. This small change in arterial saturation of oxygen with a rather large change in the pressure of oxygen indicates how tightly the oxygen attaches to the hemoglobin at pressures greater than 80 millimeters of mercury for oxygen. As the blood traverses through the skeletal muscle capillary, oxygen is transferred from hemoglobin to myoglobin in the skeletal muscle tissue, thereby decreasing the pressure of oxygen as well as the oxygen saturation percent, such that at a normal resting venous pressure of oxygen of 40 millimeters of mercury, the saturation is less than 80%. During exercise, we have an increase in the amount of hydrogen ions that are dumped into the bloodstream from the working skeletal muscle. As we have seen, this is converted into carbon dioxide, which decreases the pH and also increases the temperature of blood. That causes a shift to the right in this oxygen dissociation curve. The significance of this shift is illustrated using a partial pressure of oxygen of 40 millimeters of mercury as the reference point. As we have seen with the curve in the normal position, the arterial saturation of oxygen is approximately 80%. Whereas if I shift the curve to the right, my arterial saturation now is about 65%. This means that the affinity that hemoglobin has for oxygen is less. That means it's going to hold on to less oxygen at the same given amount of pressure of oxygen. What happened to that oxygen? Well, it was offloaded to the working muscles where it needs to go. It's important to note that this offloading of oxygen does not come at the expense of onloading at the lung, since the shift does not affect the plateau at a normal pressure of oxygen seen in the lung capillaries. An interesting question to ask is, can I increase the saturation of blood by providing supplemental oxygen? So if I give somebody a mask and they're breathing 100% supplemental oxygen, will that increase the saturation of the blood? The answer is yes. So we can go from 97 to 98% saturation to 100%. So we can increase by about 3%. But what that translates into is only a difference of 0.5 milliliters per 100 milliliters of blood. That's not a significant amount, and that's not enough to increase performance. Not only that, as soon as the athlete removed the mask and started moving, any additional oxygen that may have been dissolved in the blood and carried on hemoglobin is now dissipated. So the bottom line here is providing athletes with supplemental oxygen doesn't provide any benefit in terms of exercise performance. In terms of the transport of carbon dioxide in blood, The pressure of oxygen and the saturation of hemoglobin with oxygen also affects the transport of carbon dioxide. Carbon dioxide is transported in blood by three mechanisms. 75% of carbon dioxide is carried as carbonic acid or H2CO3. 5 to 10% of carbon dioxide is dissolved in plasma, that's the liquid or watery portion of blood. 15 to 20% of carbon dioxide is actually attached to hemoglobin. At higher pressures of oxygen levels, hemoglobin is going to carry less carbon dioxide. At low pressures of oxygen, the hemoglobin carries more carbon dioxide. This effect of the pressure of oxygen on carbaminohemoglobin, that is the carbon dioxide attached to the hemoglobin molecule, is what we call the Haldane effect. This actually enhances the carbon dioxide transport away from the working skeletal muscles where the carbon dioxide is being produced. The beauty of this system is that the low pressure of venous oxygen during exercise allows for easy removal of these CO2 molecules that are produced during exercise via this mechanism. So let's talk about some special considerations that you should be familiar with that affect the respiratory system. Oftentimes, swimmers will use hyperventilation to enhance their performance in the water. However, this is quite dangerous, as we'll see from this figure. On the y-axis, we have the pressure of oxygen as well as the pressure of carbon dioxide. On the x-axis, we have time of exercise. The green line represents the pressure of oxygen. The blue line represents the pressure of carbon dioxide. The NL represents normal pressures. The red dashed line represents the fainting threshold. This is the point at which the pressure of oxygen has reached such a low level that we go into a horizontal position. In other words, we pass out. The yellow dashed line represents where the pressures of carbon dioxide levels reach high enough to stimulate us to breathe more. This white arrow represents the time course from standing outside of the water to the point where we dive in and now we're swimming underwater. The X represents where we begin to hyperventilate. As you can see that as we hyperventilate, that is, we overventilate or purposely breathe in and out more frequently and deeper than what our body would normally tell us to do, the pressure of oxygen will increase and the pressure of carbon dioxide will decrease. I then hold my breath, jump in the water, and begin swimming. As I swim, the skeletal muscles are drawing O2 into the muscles and utilizing that oxygen. At the same time, I'm also increasing carbon dioxide levels. Now, why is this important? This is important because I will actually reach the fainting threshold with the low pressure of oxygen before the CO2 levels get high enough to tell me to come up for air to breathe more. This sets up the swimmer for a drowning. So this is a situation that you definitely want to be aware of as an exercise physiologist. Swimmers will often employ this tactic in order to not come up for air as often. We know that when we're swimming, if we have to come up for air, that actually breaks our efficiency of the swim, which means that we're going to reduce our performance. So if we hyperventilate before we go into the water, that means we're going to come up less often for air. However, this comes with a heavy price. So you can see where this would be dangerous. The person's going to lose consciousness before they actually have the drive to come up for air and breathe. That, of course, could lead to the person drowning and dying. That really defeats the purpose of competing. The next special consideration in respiratory physiology is that of performing a Valsalva maneuver. This is where we have expiration against a closed glottis. Oftentimes with resistance training, we're performing the lifting or pushing actions while the upper body is in a fixed position. Weight trainers will use this breath hold or Valsalva maneuver with the glottal closure to their advantage to try and further stabilize the thorax. As we discussed earlier with the cardiovascular lecture, this increases blood pressure quite a bit. So if you're working with patients who are resistance training or lifting heavy loads, you want to make sure that they understand that they don't want to hold their breath while performing these activities because it'll increase their blood pressure and exacerbate any underlying cardiovascular disease. As we saw in the cardiovascular module, performing a Valsalva maneuver with a leg press can increase systolic blood pressures to over 300 millimeters of mercury. That's the equivalent amount of pressure exerted by water at a depth of about 4 meters or 13 feet. If you've ever dived down to the bottom of a 9-foot swimming pool, you will recognize the effect of 300 millimeters on the body. These kinds of pressures can be deadly for those who have underlying conditions and will result in the bursting of cerebral blood vessels. In particular, you want to be careful with patients who have diabetes. Their blood vessels are particularly susceptible to bleeding. So what about a second wind? What is that? Well, in the scientific literature, we honestly don't know. We don't have good information on what that is. It's very difficult to study, and we just haven't figured it out yet. Some people believe that it is the cardiovascular system adjusting to exercise. So when that point of the demand of oxygen being met with an equal supply of oxygen, that we experience that phenomenon. But again, it's not clear in the scientific literature. The other phenomenon that's interesting is the stitch in the side, or that pain in the side that you feel with exercise onset. Again, this is a phenomenon that is very difficult to study, and we have no clue as to why that's happening, to be honest with you. So we'll see if in the future we can somehow tease out all of the different variables that play a role in the stitch in the side. Now let's talk about pulmonary diseases and the responses to exercise. COPD, or chronic obstructive pulmonary disease, also known as COLD, which is chronic obstructive lung disease. Usually it's referred to COLD in countries like the UK. COPD includes three main diseases: emphysema, chronic bronchitis, and cystic fibrosis. Chronic bronchitis is the inflammation of the bronchi. It leads to an accumulation of mucus and eventually leads to the destruction of the alveoli. Eventually, that chronic bronchitis can lead to emphysema, which is severe alveolar destruction. Cystic fibrosis is a very common and very lethal genetic disease among children. Sweat glands become hyperactive and produce sweat with high concentrations of sodium, chloride, and potassium. Interestingly, the primary cause of death, however, is from respiratory failure because thick mucus occurs in the airways. These secretions will plug the airways and promote chronic infections, thus leading to greater mucus secretion. The increased mucus production and plugging of the airways leads to airway obstruction and severe lung dysfunction that is very similar to that of emphysema. Thus, these diseases can lead to the increase in dead space contribution to each breath because of alveolar destruction. This decreases the surface area available for gas exchange. In other words, that tennis court will get smaller and smaller with alveolar destruction. An increase in dead space also increases the likelihood of a shunt. That is where we have areas of the lung where there's no gas being delivered, but yet capillaries are well perfused with blood. That leads to VAQ mismatching. This all effectively decreases the pressure of oxygen in the blood. Let's look at the ventilatory responses to exercise in individuals who have normal, healthy lungs versus those with COPD. On the y-axis, we have minute ventilation, and on the x-axis, we have oxygen consumption representing our exercise intensity level. The green line represents normal, healthy individuals. The yellow line represents mild to moderate COPD, and the red line represents severe COPD. So what does this graph tell us? As COPD progresses from mild to moderate to severe, at any given exercise intensity level, my minute ventilation is going to increase. In fact, in severe COPD patients, that really limits the capacity of that individual to complete exercise. If you recall from earlier, the lung has a 20% reserve capacity. That is, even at maximal exercise, we're only using 80% of all the alveoli available. So with mild to moderate COPD and eventually severe COPD, we have to destroy more than 20% of the lung in order to feel the effect of alveolar destruction. So we're playing tennis on a smaller and smaller tennis court. So what's that increase in VE related to? Well, it's related to the dead space contribution to each breath. Remember, dead space contribution to each breath is the percentage of each breath that's wasted in dead space. Dead space has no functional capabilities. On the y-axis, we have the VD to VT ratio. So again, this is the percentage of each breath that's wasted in dead space, where there's no gas exchange occurring. On the x-axis, we have V.O2, or the exercise intensity. In a healthy individual, as represented by the green line here, you can see that during exercise, the percent of each breath that's wasted with dead space actually is reduced. So we get more efficient at delivering that air to where it needs to go. We minimize the contribution of dead space to each breath. How do we do that? We increase tidal volume more than the frequency of breathing. In someone with mild to moderate COPD, as represented by that yellow line, you can see that the dead space contribution to each breath actually starts to increase at the higher intensities of exercise. So now we have a much higher contribution of dead space to each breath. That's space where no gas exchange is occurring. And of course, this is going to lead to an increase in minute ventilation. Someone with severe COPD, represented by the red line here, is going to increase the dead space contribution to each breath as you increase the exercise intensity level. That really increases minute ventilation and of course isn't going to allow that person to reach those higher exercise intensity levels. Let's look at the consequences of how and how much we breathe in normal and diseased individuals. The upper panel shows the arterial pressure of oxygen on the y-axis, and on the x-axis we have oxygen consumption on a per minute basis representing the exercise intensity. The green line shows us a healthy, normal individual, and as we can see, arterial oxygen saturation increases. The lung does a fantastic job of providing plenty of gas at the level of the alveolus. Somebody with mild to moderate COPD will have a reduction in their arterial level of oxygen. Someone with severe COPD significantly decreases the oxygen pressure in the arteries as they increase exercise intensity. The bottom panel shows the arterial pressure of carbon dioxide on the y-axis. The x-axis again has exercise intensity represented by V.O2. In a normal healthy individual, we see carbon dioxide levels go down as we increase exercise intensity. In mild to moderate COPD, it follows this pattern, but the pressure of CO2 is a little bit higher. In someone with severe COPD, we can see that the pressure of carbon dioxide accumulates and accumulates as exercise intensity increases. So the bottom line here is with severe COPD, we are significantly hampering the ability of the lung to perform gas exchange. That is, to bring in O2 and to expel CO2. So you've seen this graph before. That is the minute ventilation. That is the how much we breathe. Now let's explore how we breathe. How are we going to manipulate frequency of breathing and tidal volume to get this minute ventilation? In the bottom left-hand corner, we have the frequency of breathing on the y-axis, and on the x-axis, we have V.O2 for exercise intensity. In a normal, healthy individual, represented by the green line here, we expect the frequency of breathing to increase linearly and then, of course, exponentially rise as the exercise intensity gets high enough. Someone with mild to moderate COPD in yellow here has a very similar time course. However, their ventilatory threshold occurs much sooner, so at much lower exercise intensities. Someone with severe COPD, that's the red line, significantly increases their frequency of breathing. Now let's think about this. If I'm increasing the frequency of breathing, that means that I'm increasing the flow resistive work. That's going to increase energy expenditure. So someone with severe COPD really increases the amount of flow resistive work that they have to accomplish. That's not a very efficient way to breathe. However, given the circumstances of their disease, is what the human body has found to be the most efficient way to breathe. The lower right-hand corner of the screen has tidal volume on the y-axis, and on the x-axis the exercise intensity represented by V.O2. In a normal healthy individual, represented by the green line, we see that tidal volume increases and then stabilizes and plateaus. Somebody with mild to moderate COPD mimics the same pattern. However, once again, we see that this happens at lower exercise intensity levels. So exercise capacity has been reduced. Someone with severe COPD, that's the line in red, increases their tidal volume a little bit, but then has a sharp decrease. Remember that when we increase tidal volume, we are working against the elastic forces. So it appears here that the elastic forces are too great, and thus tidal volume actually decreases, which is why then we see an increase in the frequency of breathing. The bottom line here is that all of this compromises gas exchange. I think it's fair to say that most people would agree that smoking cigarettes is not good for your health. Nicotine is one of the top 5 most addictive substances on this planet, only preceded by heroin and cocaine. When we smoke cigarettes, we increase alveolar destruction. So that means we're increasing the amount of dead space that we have in the lung. Now, most people who smoke will tell you it hasn't affected their ability to exercise or perform ADLs, that is, activities of daily living. However, remember we have a 20% reserve of the lung. So as we continue to smoke cigarettes, we induce chronic bronchitis, which then causes alveolar destruction. So that alveolar destruction eventually gets bad enough where then it's categorized as emphysema. Emphysema then is going to reduce our exercise capacity because we've gone beyond that 20% reserve. So smokers may not experience the ill effects of their smoking until many decades later. At that point then, it's too late. As we have seen in these graphs, patients who have severe COPD have no options when it comes to breathing. If they increase the frequency of breathing, that increases the contribution of the flow resistive work. If they increase the tidal volume, that increases the elastic work. So these patients have absolutely no options in terms of how they breathe. Anything they do is going to decrease the pressure of oxygen as well as increase the pressure of carbon dioxide. They simply have no options. I want you to try these activities at home. I want you to try to first breathe with a hyperinflated lung. That is, take a breath in and try to breathe in and breathe down, but breathe back down to that higher lung volume that you just created. So here's an example of what that might look like. So I'm going to take a breath in. So I'm breathing with a hyperinflated lung. And this is exactly what happens in people who smoke and who have COPD, therefore emphysema. The lung wall actually expands out. It's hyperinflated. And the reason for that is because you have so much alveolar destruction that the lung becomes floppy. It has higher compliance, is what they say. So that is actually going to force the lung to have more air in it. So you're breathing at a much higher lung volume. Your FRC is increased. So that is going to increase the energy expenditure because you have to now breathe in and increase the tidal volume. That's not a good option. That's going to increase the amount of energy that the respiratory muscles are going to have to expend in order to maintain minute ventilation. The other activity I want you to do is to take a straw. Take a straw, plug your nose, and breathe in and out of the straw. That will also give you a sense of what these patients are going through. If I increase the frequency of breathing, I'm increasing the flow resistive work that I have to do. That is going to increase the energy cost of breathing. So now if we combine these two, and we breathe with a hyperinflated lung as well as breathing through a straw, here's how it might look. That was really hard. And it increases the energy cost of breathing. In fact, these patients spend so much energy in ventilating, in the how and the how much they breathe, that they expend so many calories they end up losing a lot of weight. It's kind of interesting, in the 1970s, smoking was actually promoted as a way to lose weight. Yeah, I probably wouldn't subscribe to that plan. That's just going to lead to an increase in alveolar destruction, and you're not going to be able to perform any kind of ADLs doing that. If you try this at home, you're going to experience exactly what COPD patients may be going through breath to breath. Every breath they take is a struggle for survival, a struggle to maintain alveolar ventilation. And no matter what they do, whether they increase the frequency of breathing or whether they increase tidal volume, all of it is ineffective. It just doesn't work properly because there's so much alveolar destruction. So the bottom line here is patients with severe emphysema die a slow, miserable death. They really do. It's sad and it's completely preventable. All we have to do is not expose ourselves to cigarette smoke or secondhand smoke. It's that simple. What's really sad to me is that you have children with cystic fibrosis who never smoked a cigarette a day in their lives, end up with emphysema, and who end up dying a slow, miserable death as a result of this disease because of some genetic variant. So with COPD, we have a mismatching of VAQ. We have an increase in the dead space contribution to each breath that reduces the arterial level of oxygen pressure, which then increases the ventilatory requirement. COPD also increases airflow obstruction, which increases the work of breathing, which then increases respiratory muscle fatigue, and of course reduces ventilatory capacity. All of these lead to exercise limitations. So the question becomes, can we rehabilitate these folks who have COPD? Can we increase exercise capacity? Absolutely. We can get them to improve their functional capacity a little bit. Can we improve their breathing with breathing exercises? The answer is no. Remember that there are neural and humoral inputs that regulate the amount of breathing based off of the energy expended or the energy cost of breathing. Can we improve our pulmonary function tests or PFTs? The answer is yes and no. So sometimes it can, sometimes it doesn't. Can we train the respiratory muscles so that we can improve ventilation? The answer is yes, we can do inspiratory muscle training. That requires the use of a little special device placed in the person's mouth, which increases the amount of pressure it takes to breathe in and to exhale. That will improve the function of the respiratory muscles. So let's shift gears a little bit and talk about exercise-induced asthma. It's also known as exercise-induced bronchospasm. This is not to be confused with asthma. There is a distinct difference. Let's talk about that difference. With exercise-induced bronchospasm or exercise-induced asthma, it's acute, it's reversible, and the obstruction is usually self-terminating. So in other words, there's no inflammation. With asthma, you get inflammation. With exercise-induced asthma or exercise-induced bronchospasm, remember those two are the same, we don't have the inflammatory piece. EIB typically happens during or after strenuous exercise or hyperpnea, that is, breathing more. It especially manifests when we breathe dry and or cold air. So if we're running outside on a cold winter day, that's going to exacerbate somebody's EIB. We also see this in atypical or latent asthmatics. So you might have asthma, which includes the inflammatory response in the bronchi, and have exercise-induced bronchospasm. Usually the diagnosis occurs early on when we're kids, which brings the question of, can we outgrow the EIB? And the answer is a little bit. About 60% of people who are diagnosed with asthma when they were kids will actually have it reappear when they're 50 to 60 years old, usually when they end up with pneumonia and end up in the hospital. Just remember that asthma is distinctly different from exercise-induced bronchospasm or exercise-induced asthma. Those are different from asthma. So EIA and EIB are different from asthma. With asthma, you get an inflammatory response. With EIB, it's going to be acute, so it's at the onset of exercise, especially with dry, cold air. It's completely reversible, and it only involves the bronchospasm of the bronchi. So in other words, the bronchi are narrowing. There is no inflammation with EIB. So is there any way around exercise-induced asthma or exercise-induced bronchospasm? There are some ways that you can get around this. Some good activities are going to be those that are stop and go. You could exercise for 2 minutes and then rest for 2 minutes, and then exercise for 2 minutes and then rest for 2 minutes. If you do this for a warm-up for the first 15 to 20 minutes of exercise, then you can actually alleviate inducing the EIB. The other option is to just simply run through the exercise-induced bronchospasm. That is, to tolerate it for the first 10 to 12 minutes of exercise. Typically then, it will reverse and you'll be able to exercise normally. The benefit of this kind of stop-and-go activity is that there's a refractory period of about 1 to 3 hours. So in other words, you won't experience another EIB event in 1 to 3 hours as a result of doing these kinds of activities. Water activities are also great, particularly indoors, because of the humid atmosphere. It's interesting to note that about 14% of swimmers actually present with asthma. The other tactic that you can employ is to avoid the pressures of competition, which is easier said than done. The overall objective of a physical conditioning program is to improve self-image and, of course, increase fitness levels. So specifically, you want to help the child become more comfortable with participating in sport despite having the EIB. The goal should be to increase the level of cardiovascular fitness and promote proper breathing techniques, that is, relaxation techniques. And of course, we want to strengthen the breathing muscles. On a final note, we should never use EIA or EIB as a reason to avoid exercise. There are too many tactics that we can employ that help people participate in sport or exercise activities. Of course, some of those tactics would include bronchodilators, which dilate the bronchi. So in summary, what have we talked about in this lecture? We've talked about the factors that affect gas exchange. We talked about ventilation, the how and how much we breathe. We talked about diffusion and the driving pressure and the surface area available for gas exchange. We also talked about the VAQ matching. That is how well we've matched gas with blood to enable gas exchange to occur. We've also talked about the mechanics of breathing, how the elastic and flow resistive forces are mitigated in order to minimize the energy expenditure of the respiratory muscles when it comes to bringing air in and out of the lung. We talked about the control of breathing, the neural factors as well as the humoral factors that play a role in determining how and how much we breathe. We also talked about the transport of carbon dioxide as well as oxygen. We discussed that the bulk of carbon dioxide is transported as carbonic acid in the blood, and that's related to the amount of hydrogen ion that's being dumped into the bloodstream from skeletal muscle. We also talked about the oxygen dissociation curve and how oxygen is bound to hemoglobin and that the saturation of oxygen on hemoglobin is dependent on the pressure of oxygen. The lower the pressure of oxygen, the more that we get offloading of oxygen from hemoglobin into the skeletal muscle. And lastly, we looked at COPD and how there's an increase in dead space contribution to each breath due to the lung destruction that's going on from that disease process. This is going to alter that minute ventilation, so how much we breathe. It'll affect alveolar ventilation, of course diffusion, and the VAQ matching. So let's run through a few scenarios for you to think about. What happens if I ask you to increase the stimulus to breathe, so you breathe more deeply? So basically we're hyperventilating, right? What's happening? We're decreasing the level of CO2 and increasing the level of O2. What about the work of breathing in that scenario? Since we're expanding the chest cavity more, we're going to increase the elastic work that we have to complete. What about if I breathe with a hyperinflated lung? So I take in a breath of air and now I try to breathe in deeper. So essentially we're mimicking COPD with a hyperinflated lung. Remember, that gives you the barrel chest. What's happening there? Well, more air is trapped in the lung. That's actually going to increase the level of carbon dioxide that's trapped in the lung because you can't exhale it out. We also have to manipulate our breathing such that we're increasing the frequency of breathing a little bit more rather than the tidal volume, because remember, that costs more energy now to expand that rib cage out beyond what we already are expanded to in terms of the hyperinflation that's going on. So that increases the elastic work that we have to contend with. What about if someone was standing on your chest? Please don't try that. That's kind of dangerous. But if someone was standing on your chest, what would that do to your breathing? Obviously, that's going to reduce your overall minute ventilation, and it's also going to decrease your tidal volume quite a bit because your chest cannot expand out. So what other option do you have in terms of breathing? The only other option you have is to increase the frequency of breathing. You don't really have the option of expanding the chest wall because someone's compressing or restricting the movement of the thorax. What about if you have a patient who's morbidly obese? Someone who's morbidly obese has a very massive chest wall, and that chest wall now is much more difficult to expand the chest cage. So we're going to, of course, rely more on the other option, which is to increase the frequency of breathing. The consequence of that is, well, we're going to increase the flow resistive work. So not a good option as well. What about if you had a track runner and you're the coach and you tell that track runner, I really don't like the way that you're breathing. I want you to start breathing through your nose and out your mouth and breathing deeper. Is that a good tactic to employ? No, it's not, right? So if we think about the mechanisms that control breathing, we know that the nervous system has some input in there, but we also have the humoral component that's going to fine-tune how we breathe and how much we breathe. And we're regulating the how much we breathe and the how we breathe by manipulating the frequency of breathing as well as the tidal volume. And we're going to find the best combination of those two that minimizes the energy cost to breathe. At some point during exercise, everyone will open their mouths to breathe and will stop breathing in through their nose and out their mouth. The exchange of air in the lung will occur solely through the mouth. What about if you had a COPD patient and you told them that you didn't like how they were breathing? And remember, that COPD patient is going to breathe with a hyperinflated lung as well as breathing through a straw. So again, let me show you what that looks like. Can you walk into a patient's room and tell that patient that they need to change their breathing pattern? Well, you can, but the minute that you close the door and leave the room, they're going to go back to breathing to the way that they were breathing when you first walked in the room. So you can tell them to breathe with pursed lips and to slowly breathe in and out, but that is not maintainable over the long run. It's all based on the energy cost of breathing, and the body will manipulate the frequency of breathing and the tidal volume to minimize that energy cost. So while we can do breathing exercises to strengthen the respiratory muscles and for relaxation purposes, that is not sustainable for the long term. What if we had a restrictive disease? So something like sarcoidosis, where the lung is not allowed to expand. How are we going to breathe? How is that going to change things for us? Well, again, if we're restricting the lung movement, then we can't expand outward, so we can't increase tidal volume. The only other option we have here is to increase the frequency of breathing. And the problem with that is we increase the flow resistive work. Lastly, breathing through a straw. What's the problem here? So if I'm breathing through the straw, what's the issue? The issue is I'm increasing the flow resistive work. And that is going to affect my minute ventilation, and of course, it's going to affect my blood gases.